Welcome back to the Deep Dive. Our mission today is laser-focused, and the stakes are incredibly high.
They really are.
We're not just summarizing a drug here. We are crafting the perfect, high-scoring answers specifically for you, an MD anesthesiology candidate getting ready for those demanding Gujarat University written papers, and of course, the critical Viva exams.
Exactly.
We've taken all the core pharmacology, the dense textbook sources, and we've synthesized them into the exact structure that your examiners are looking for.
Precisely. You should think of us as your senior faculty, just walking you through the absolute mandatory material. Isoflurane is, well, it's the essential bridge agent.
Bridge agent, I like that.
It is. It's the cornerstone that lets you compare and contrast all the safety advancements from halothane all the way to sevoflurane and desflurane.
Okay.
To get those top marks, you simply must master isoflurane's pharmacology. So we're going to frame this whole discussion around what we call the 3 pillars of isoflurane, which really define its entire clinical profile.
And what are those?
First, its intermediate speed. Second, its superior safety profile because of its minimal metabolism. And third, its predictable maintenance of cardiac output.
Okay, let's unpack this immediately then. Starting with that mandated definition, the one that has to be the very first line of any long answer. What is isoflurane chemically?
Right. So chemically, it's a halogenated methyl ethyl ether.
Okay.
But you must immediately add the critical structural note. It is a structural isomer of Enflurane.
Isomer, so same formula, different layout.
Exactly. And you have to remember, that tiny difference in arrangement is what accounts for isoflurane's dramatically superior clinical profile. It just doesn't have the seizure-inducing properties that plagued Enflurane, which is why it so quickly became the agent of choice.
So that one structural tweak really made all the difference.
It did.
Where does it sit in the historical timeline of these volatile agents?
Well, isoflurane was introduced in 1981, and that date is a real marker. It fundamentally replaced its isomer Enflurane in pretty much all clinical settings. Historically, it's the agent that solved the biggest problems of the agent from the 50s, halothane.
Which were its liver toxicity and the arrhythmias, right?
Specifically, its hepatotoxicity and its nasty habit of sensitizing the heart to arrhythmias. So isoflurane represents that crucial intermediate solubility agent. It bridged the gap between the slow, highly soluble halothane and the super fast modern agents like Sevo and Des.
So you get that intermediate speed.
Intermediate speed, but critically a completely new level of metabolic stability.
So the story of isoflurane is really the story of moving away from those older, metabolically risky agents toward safer ones.
Absolutely. It defined the next decade of volatile anesthesia safety. And that narrative, that problem-solving aspect, is what scores you marks in the exam.
Right. Now let's frame this for the examination itself. If you get a question on isoflurane, what are the likely ways the examiners will ask it?
They love isoflurane for questions because it's just a perfect vehicle for a complete pharmacology test. You have to be ready for 3 scenarios. First, the big one.
The long answer.
The massive long answer, a 20-mark question demanding a full, structured pharmacology review. Everything from chemical properties, pharmacokinetics, pharmacodynamics, clinical uses, the whole thing.
And the systematic approach we're using today is basically the blueprint for that.
It is the required blueprint for that 20-mark essay, yes.
Okay, and what about the shorter, more surgical strikes, the short notes?
Right, those are your short notes, usually 5 to 10 marks. Examiners will pick out controversial or high-yield topics to test your depth on just one system or a comparison.
Okay.
Things like isoflurane and coronary steal syndrome, which needs a really nuanced historical answer, or the effects of isoflurane on the CNS and ICP management, which needs precision about that 1 mmHg threshold.
Or just a straight comparison?
Or a straight comparison, isoflurane versus sevoflurane. And then finally, for your Viva preparation, fluency with the numbers is everything. The MAC, which is 1.17%, the blood gas partition coefficient, 1.4. And you have to be able to justify that seemingly contradictory idea of maintaining cardiac output even with profound vasodilation.
Okay, mastery of isoflurane really starts with those physical numbers because they directly predict how it behaves in a patient. Let's start by revisiting its structural stability.
Right. We said it's a halogenated methyl ethyl ether. The structural detail to really emphasize here is how it compares to desflurane.
Mm-hmm.
Desflurane is basically isoflurane, but with a single chlorine atom swapped out for a fluorine atom. And that tiny change, as we'll see, dramatically lowers its solubility and cranks up its vapor pressure.
But for isoflurane itself, the key is stability.
Extreme physical stability. It doesn't break down. You can store it for 5 years, expose it to CO2 absorbance, sunlight. It's fine.
And that's why you don't need any preservatives.
Exactly. It obviates the need for preservatives, unlike halothane, which famously needed that 0.01% thymol to stop it from decomposing into toxic acids. This stability is a massive, massive safety win.
That explains the long shelf life. But that stability has a clinical downside, doesn't it? Specifically, its smell.
Yes. That high stability and its chemical makeup translate into a huge clinical limitation. Its pungency.
It's a very distinct smell.
Oh, it has a pungent ethereal odor. And this is exactly why it is almost never used for inhalational induction.
Especially in kids.
Especially in children or, uncooperative adults. It just causes irritation, coughing, salivation, breath holding, even laryngospasm. Sevoflurane and halothane are far better for mask induction because they're non-irritant or sweet-smelling.
So that pungency really restricts isoflurane to maintenance after you've already induced with an IV agent.
Primarily, yes.
Okay, let's get to the vital physical properties, starting with volatility.
Volatility is described by the saturated vapor pressure, the SVP. For isoflurane, this is 238 mmHg, or sometimes you'll see 250 mmHg at 20 degrees Celsius.
And why is that specific number important for the exam?
It's important because it's almost identical to halothane, which is 243 mmHg. This is the reason isoflurane can be given reliably using the older, conventional, temperature-compensated vaporizers, the Tech series vaporizers.
So no special equipment needed?
No significant modification needed. If you have a very high SVP, you need a special vaporizer to handle it. But isoflurane's pressure is moderate and well handled by standard devices.
Okay. Next, the ultimate decider of speed. The blood-gas partition coefficient, lambda big.
This is one of the 3 non-negotiable numbers you have to know. The lambda big is 1.4.
1.4.
Where you might see 1.46. And as we said, this is the very definition of intermediate solubility. For context, you should always say halothane is slow at 2.3 to 2.5. Sevoflurane and desflurane are fast at 0.65 and 0.42.
So 1.4 is right in the middle.
Right in the middle. It means it takes longer to saturate the blood than Sevo or Diz's, but much, much less time than halothane.
And what's the clinical relevance of that intermediate speed?
The primary relevance is control. Induction and recovery are, relatively quick compared to halothane, which allows for faster turnover in the operating room.
Right.
The alveolar concentration, or FA, reaches half the inspired concentration, FI, in about 4 minutes. So this intermediate solubility gives us excellent control. We can change anesthetic depth reliably, but without the really violent partial pressure swings that can complicate desflurane, especially in low-flow circuits.
Okay, now let's talk potency, which is driven by lipid solubility. That's the oil-gas partition coefficient.
Right. The lambda OG for isoflurane is high. It's in the range of 91 to 99.
And what does that tell us?
Well, according to the Meyer-Overton hypothesis, lipid solubility is inversely proportional to MSE. So a high oil-gas coefficient means high potency.
That's a potent drug.
Very potent. For comparison, desflurane has an oil gas of only 19, making it far less potent. The high lipid solubility of isoflurane lets us achieve surgical depth with pretty low inspired concentrations, say around 1.5%, compared to sevoflurane, where you're often using 2.5% to 3.5%.
And finally, the universal yardstick of potency. Minimum alveolar concentration, MAC. Give us the core adult number and the key modifiers.
The standard MAC for a middle-aged adult is 1.15% to 1.17%.
Okay.
You should also know the corresponding partial pressure, the MAPP, which is 9.1 mmHg. This number is your benchmark for all dosing. But you must also know that MAC is highly age-dependent. This is a Viva favorite.
Right.
It decreases by about 6% per decade of age after the first 2 decades. And the highest MAT requirement is actually in infants, peaking around 6 months old, where you might need 1.6% or even 1.9%.
So it's not a fixed number, it's a dynamic parameter.
Exactly. It's influenced by the patient's physiology.
Okay, let's transition from the physical numbers to the mechanism. How does isoflurane actually create the state of anesthesia?
Right, and you have to approach this with some sophistication in the exam. General anesthesia isn't just one thing. It's a reversible state made up of hypnosis, that's unconsciousness, analgesia, amnesia, and immobility. Immobility is what we're measuring with ME.
And the mechanism is complex.
It's very complex. It involves modulating tons of different membrane proteins and ion channels in both the CNS and the peripheral nervous system. A common exam mistake is to just say it works on one receptor.
Right.
You need to stress that loss of consciousness, amnesia, and immobility are now understood to be separate things happening at different sites.
Okay, so if the effects are separated, where is the primary site for isoflurane's immobility? This seems like a key point.
It is an essential knowledge point. The immobilizing action, the MISC effect, is primarily mediated at the spinal cord level.
The spinal cord, not the brain.
Primarily. This is proven by studies showing that the MSC needed to stop movement is pretty much unchanged even after decerebration. That's removing the brain above the brainstem. Volatile agents work by suppressing the motor output of that withdrawal reflex, and they do it at the level of the spinal cord gray matter.
Okay, let's go to the molecular level. This is what separates a good answer from a great one. What molecular targets are we talking about?
Well, while a lot of anesthetics work on the inhibitory GABA receptor for isoflurane's immobility action, its effects on GABA receptors are surprisingly unimportant.
That's interesting.
It is. Instead, the focus is on modulating ion channels that control how easily neurons can fire. So key mechanisms are inhibiting voltage-gated sodium channels, which stabilizes the neural membrane.
Okay.
And crucially, research also points to the two pore domain potassium channels, or KGP channels, specifically TAS1, TAS3, and TREC1. By opening these channels, isoflurane hyperpolarizes the neurons, making them harder to fire.
So it's multiple targets, not just one receptor.
Exactly. Multiple targets creating the overall anesthetic state.
So let's just solidify the clinical use of MA. It's an ED50 dose, so how do we translate that into what we actually need in the operating room?
Right, you need to remember the ratios. M is ED50, so 50% of people don't move.
Which is not good enough.
Not nearly good enough for surgery. For clinical reliability, you want to prevent movement in 95% of patients. So we aim for MAIC 95, which is roughly 1.3 MA.
And on the other end, for waking up.
For emergence, about 0.3 to 0.4 MASC is generally associated with awakening. We call that MAS wake.
Right.
And a highly testable concept is the additivity principle. MAS values are roughly additive for immobility. So 0.5 MAS of isoflurane plus 0.5 MAS of nitrous oxide gives you the equivalent immobility effect of 1.0 MAS of a single agent.
But that's just for immobility, not necessarily for the other effects.
That's a crucial point to make. It applies to immobility, but not necessarily to, say, cardiovascular depression.
All right, moving on to pharmacokinetics. What the body does to isoflurane. This is that journey from the vaporizer through the lungs and into the brain. Let's detail that uptake process.
Okay, so the overall uptake is a sequence of transfers. It goes from the vaporizer into the alveoli, into the arterial blood, and then finally it gets distributed into the tissues. First to the vessel-rich groups, brain, heart, liver, kidney.
And its intermediate solubility is key here.
It's key. Because we established that lambda big JAG of 1.4, it saturates the blood relatively quickly. That intermediate solubility allows the alveolar concentration, the FA, to rise pretty fast towards the inspired concentration, the FI.
Giving you that predictable intermediate induction speed.
Exactly. And distribution follows a classic 5-compartment model, hitting the vessel-rich groups first, then muscle, then fat.
So what are the primary factors that control how quickly that alveolar concentration rises? This is a common exam question.
You have to categorize them clearly. First, delivery factors. These are the things the anesthetist controls.
Like the vaporizer setting.
Exactly. Your inspired concentration set on the vaporizer and the fresh gas flow. High fresh gas flow flushes the circuit, keeping the inspired partial pressure high.
Okay, what's next?
Second, ventilation. This is critical. Increasing the minute ventilation speeds up the rate of rise of FA towards FI. And since isoflurane is moderately soluble, increasing ventilation has a really substantial effect on speeding up induction.
More so than for a really soluble agent like halothane?
Much more so, yes. And third, you have uptake factors. This includes solubility, but most importantly, cardiac output.
And this is the counterintuitive one for a lot of students.
It is. A high cardiac output slows the rate of induction.
Right, because you're washing the agent away from the lungs faster.
Exactly. More blood flows through the lungs, washing the agent away from the alveoli, which delays the rise of the alveolar partial pressure. Conversely, a patient in shock with a low cardiac output will have a very rapid rise, and they're at risk of an overdose if you don't anticipate that.
Right. Let's pivot to what you call the second pillar of isoflurane. It's metabolism and elimination. Why is this section so important?
Because of one number. Less than or equal to 0.2% of the absorbed dose is metabolized.
That's tiny.
It's the lowest rate of biotransformation among all the currently used volatile agents, and when you write this in your exam, you must contrast it. Halothane is 20-40% metabolized, sevoflurane is 2-4%. This minimal metabolism translates directly into minimal toxic risk. That's the cornerstone of its safety.
So tell us about the metabolic pathway. What are the breakdown products?
Well, primary elimination is just simple exhalation. The tiny bit of metabolism that does happen is done by the liver enzyme cytochrome P452E1.
Okay.
And this oxidative process produces two main metabolites, inorganic fluoride ions and trifluoroacetic acid, or TFA. TFA is the main end product, and it gets excreted by the kidneys.
And what is the huge clinical significance of these being produced in such tiny amounts?
You have to state two clear points for the exam. First, low hepatic toxicity.
Right.
Minimal TFA production means minimal risk of TFA-mediated neoantigen formation. That's the mechanism behind the rare but devastating halothane hepatitis. Isoflurane basically eliminated this risk from clinical practice.
And the second point?
Low renal toxicity. Because the fluoride production is negligible, serum fluoride levels stay below 5 micromoles, we completely avoid the high output renal failure that was seen with agents like methoxyflurane. Even if you use it for ICU sedation for over 24 hours, the small rise in fluoride is clinically insignificant.
So this superior safety margin makes it great for long cases.
Highly favorable for long surgical cases, yes.
Okay, we've hit the first two pillars, intermediate speed and minimal toxicity. Now for the third, and maybe the most complex one, hemodynamics. Isoflurane's effect on the cardiovascular system is tested all the time.
It is. And this section has to be detailed and nuanced. Isoflurane's cardiovascular profile is defined by a kind of dichotomy. It's a myocardial depressant in a petri dish, but the clinical profile is masked. The most significant hemodynamic effect is a marked dose-dependent drop in systemic vascular resistance, or SVR.
So where does this profound vasodilation happen, and how does that cause hypotension?
The vasodilation is significant. It's a direct relaxation of the vascular smooth muscle. And you see a proportionally greater drop in resistance in the skin and muscle beds compared to vital organs.
That's the main cause of the drop in blood pressure.
It is the primary, almost singular cause of hypotension during isoflurane anesthesia. Your answer must clearly state, the hypotension is SVR-driven, not contractility-driven.
But here's the critical clinical contradiction. The examiner expects you to say that cardiac output is generally well maintained. So if SVR plummets and blood pressure falls, how is cardiac output preserved up to 2 MAC?
This is the 20-mark analysis point. Cardiac output is generally preserved. It stays close to awake levels because of a highly effective compensatory mechanism, a reflex increase in heart rate.
The body fights back.
It does. Isoflurane only partially blunts the baroreflexes, so the sympathetic system kicks in. This compensatory tachycardia effectively counteracts the drop in afterload and the mild direct myocardial depression.
Okay.
It also has some mild beta-adrenergic agonist properties that help. If you can explain that feedback loop SVR drops, heart rate increases, cardiac output is maintained, you demonstrate mastery.
That compensation is absolutely key. Now, we did note that rapid increases in concentration can trigger tachycardia. Is that a major clinical problem?
It can be, yeah. Particularly in young, healthy adults who have a really robust sympathetic response. A rapid increase in isoflurane concentration can lead to a transient tachycardia and hypertension, which is mediated by that sympathetic outflow.
It's like the effect you see with desflurane, but milder.
Similar, but typically milder than the pronounced surge you see with desflurane, yes.
Okay, let's spend some significant time on the Viva favorite, coronary blood flow and the coronary steal concept. This topic gives candidates a lot of anxiety. How do we structure the perfect answer?
You start by acknowledging the physiology and the historical concern.
Okay.
1, the mechanism. Isoflurane is a very potent coronary vasodilator, and crucially, it preferentially dilates the small coronary resistance vessels, the ones that are responsible for autoregulation.
And 2, the theoretical concern.
Right. In patients with severe coronary artery disease who have fixed blockages, the blood supply to the heart muscle often relies on collateral vessels that are already maximally dilated. So, if isoflurane dilates the normal coronary arteries, it could theoretically divert blood, or steal it, away from that critical collateral-dependent ischemic area that needs it most. This was a huge theoretical fear in the 1980s.
So if the mechanism is sound, why do we still use it all the time in cardiac surgery? How do we give the examiner approved answer?
The approved answer is grounded in overwhelming clinical evidence. While the steal phenomenon was shown conclusively in some animal models, specifically heavily instrumented dogs, it has not been confirmed in human clinical studies to increase the incidence of myocardial ischemia or bad cardiac outcomes.
So the human heart is different.
You have to stress 2 points. First, the human coronary circulation is far more complex than the animal model suggested. And second, the clinical impact of just maintaining the systemic perfusion pressure outweighs the theoretical vasodilation effects. If you keep the blood pressure up and the heart rate controlled, isoflurane is safe.
Wait, not just safe, but we now think of it as protective, don't we?
That's the modern nuance that gets you the high mark. Isoflurane is now recognized for its intrinsic cardioprotective properties, a phenomenon called anesthetic preconditioning.
Okay.
This involves molecular pathways that actually make the heart muscle more resistant to ischemic injury. So, in a well-managed patient, the risk is theoretical, the safety is high, and the potential for preconditioning is a bonus.
That really puts the CVS debate to rest. Let's move on to respiratory effects.
Isoflurane causes dose-related respiratory depression, just like its peers. This leads to a decreased tidal volume and an increased respiratory rate.
But the net result is a drop in ventilation.
Exactly. The net result is a significant reduction in minute ventilation, which causes a dose-dependent increase in PaCO2. You almost always need to assist or control ventilation to avoid hypercarbia.
And what about the critical effects on the chemoreceptors?
This is key. Isoflurane profoundly blunts the normal ventilatory response to hypoxia. This response is impaired at concentrations as low as 0.1 mmHg, and it's basically abolished by 1.1 mmHg.
So the patient loses their safety net.
They do. It specifically depresses the peripheral chemoreceptors, like the carotid body, and similarly, it depresses the response to hypercapnia. This means if the patient is breathing on their own, they have lost their ability to defend against low oxygen or high carbon dioxide.
And we mentioned the pungent odor. What's the airway consequence of that?
It remains a major practical limitation. The irritating odor limits its use for inhalational induction, causing coughing, salivation, and breath holding. However, once the patient is anesthetized, isoflurane is actually a good bronchodilator, which makes it useful for patients with asthma or bronchospasm.
Okay, now cerebral effects, which is vital for neuroanesthesia. We need to be really precise about that 1 mmHg dividing line.
Absolutely. Start with metabolism. Isoflurane significantly reduces the cerebral metabolic rate of oxygen, or CMRO2. This is dose-dependent and nonlinear. The biggest metabolic reduction happens at concentrations below 1 mA. At higher doses, say 2 mA, isoflurane can produce an electrically silent EEG, which is a marker sometimes used for maximum neuroprotection.
But the downside of volatiles in neurosurgery is always the risk of increasing intracranial pressure. How does isoflurane balance that?
This is the high-scoring conceptual answer. Isoflurane causes cerebral vasodilation, which increases cerebral blood flow. But this effect only becomes significant at concentrations greater than 1 ms. Below 1 ms, metabolic coupling is largely preserved. The blood flow reduction follows the metabolic rate reduction, so you don't get a massive increase in flow.
So if you go above 1 ms, that's when you start to see the ICP rise.
Exactly. Above 1 ms, CBF increases, leading to increased ICP.
So the rule in neurosurgery is to stay below 1 ms.
Not necessarily, but you have to be proactive. The crucial advantage of isoflurane is that the ICP increase caused by that vasodilation is reversible with controlled hyperventilation.
Okay.
Hyperventilation decreases PaCO2, which powerfully constricts cerebral vessels, and that counteracts the isoflurane effect. This is a massive advantage over halothane.
Right.
And finally, isoflurane also helps CSF absorption, which is a good thing for managing CSF dynamics.
Okay, quickly, what about other organ systems?
Neuromuscular system. It gives you good skeletal muscle relaxation and significantly potentiates non-depolarizing muscle relaxants, more so than halothane. So you need a smaller dose of your relaxant.
And renal.
Renal system. It does decrease renal blood flow and GFR, but this is mainly due to the drop in blood pressure. It's transient, and because there's no significant fluoride production, it's not associated with long-term nephrotoxicity.
And finally, the liver.
Hepatic system. Total hepatic blood flow is reduced, but critically, the oxygen supply to the liver is better maintained compared to halothane because hepatic artery perfusion is relatively preserved. So liver function tests are usually unaffected.
Okay, so having defined its pharmacology, let's summarize its role in modern practice. Where is isoflurane primarily used today?
Its primary foundational role is the maintenance of general anesthesia. It's reliable, it's predictable, it's cost-effective, and it offers that great balance of moderate potency, predictable cardio function, and crucially, metabolic safety.
Let's focus on the specialty areas. First, its use in high-stakes cardiac surgery, especially after that whole coronary steel debate.
Right. Despite the theoretical concerns, which you should always acknowledge in an answer, isoflurane is routinely used in procedures like CABG. As we discussed, extensive human data shows no increased incidence of myocardial ischemia when compared to other agents, as long as you control the hemodynamics. And the added benefit now is that we recognize it as a cardioprotective agent via anesthetic preconditioning.
Which is a huge advantage in ischemic hearts.
It's a significant clinical advantage, yeah.
And in neuroanesthesia, where precision is everything.
Isoflurane is highly preferred over older agents like halothane. Its ability to predictably reduce the brain's metabolic rate is key, and the fact that the CBF and ICP increases only really happen above 1 mmHg and are easily manageable with hyperventilation makes it an excellent choice for craniotomies.
Right.
And its positive effect on CSF dynamics just solidifies its utility there.
Finally, we should emphasize its use in really long surgical procedures.
This is where its minimal metabolism really shines. For cases that go on for hours and hours, the risk of accumulating toxic metabolites is almost eliminated. That tiny 0.2% biotransformation makes isoflurane highly suitable for long cases and even for continuous sedation in the ICU for more than 24 hours.
Something you could never do with halothane.
Absolutely contraindicated due to toxicity accumulation.
All right, left for practical administration and the factors that change the dose you need.
Standard maintenance concentrations are typically between 1% and 2%. If you need to deepen the anesthetic quickly, you might briefly go up to 1.5% to 3.0%.
But the critical exam knowledge here is about the MAC modifiers.
It is. Reciting and understanding the MAC modifiers is key.
So what are the main factors that decrease isoflurane MAC? This is a mandatory Viva question.
You must be able to list 5 or 6. The most significant factor is increasing age, with that 6% reduction per decade.
Okay.
Other vital decreasing factors are hyperthermia, hypoxia, specifically a PO2, less than 40 hypovolemia or acute blood loss.
And pregnant.
And pregnancy. MC is substantially reduced, sometimes by 35% to 40% at term. And then also pharmacological agents like alpha-2 agonists, opioids, and benzodiazepines.
And conversely, what makes you need more of the agent? What increases the required concentration?
MSC is increased by hyperthermia, young age. Remember that peak at 6 months, chronic alcoholism?
Right.
And certain drugs like cyclosporine. It's also important to remember what doesn't alter MAC. Things like the patient's sex, height, weight, or chronic blood pressure issues generally do not change MA.
Let's look at the quantitative drug interactions, specifically with nitrous oxide and opioids.
This tests your knowledge of synergy. For nitrous oxide, the classic example, using 70% N2O roughly halves the isoflurane MA.
And for opioids like fentanyl.
You should cite the key number. A 50% reduction in isoflurane MA is achieved at a plasma fentanyl concentration of 1.67 nanograms per mil.
But there's a limit to that effect, isn't there?
There is, and that's the crucial caveat, the ceiling effect. Fentanyl and other opioids are potent MSC reducers, but they are not complete anesthetics. They can reduce the requirement by about 50–70%, but they can't get you to zero MSC alone. You always have to combine them with a volatile or IV agent for full immobility.
Okay, we've established the 3 pillars. Let's synthesize these into the clear, actionable advantages that explain why isoflurane is still so widely used.
The first major advantage, coming from that 3rd pillar, is the predictable hemodynamic stability. The cardiac output is maintained because of that effective reflex tachycardia. This gives us a much wider margin of cardiovascular safety compared to the profound direct myocardial oppression you see with halothane.
The second, and maybe the greatest safety advantage, comes from the second pillar.
The minimal metabolism of less than or equal to 0.2%. This is its defining feature. It translates directly into minimal risk of halothane-like hepatitis and negligible fluoride-related renal toxicity. This makes it an ideal agent for long cases and in patients with liver issues.
And what about practical use in the OR, like cost and using it with adrenaline?
Well, it is notably cost-effective, which ensures its routine use all over the world, especially in resource-constrained settings.
Sure.
And regarding safety, it's non-flammable, and crucially, it does not sensitize the heart to adrenergic arrhythmias. This means we can safely use epinephrine for local vasoconstriction at doses up to 4.5 micrograms per kilo. That's 3 times higher than the limit with halothane.
So that non-arrhythmogenic property is a major clinical safety feature.
A major feature, yes.
All right, every agent has its downsides. For the exam, what are the key adverse effects and complications that you have to discuss?
The most common and clinically relevant side effect is hypotension. And you must clearly define this as dose-dependent and primarily due to the reduction in SVR from vasodilation.
And closely linked to that is?
Tachycardia. It can be transient, but it can happen with rapid increases in concentration or in young, healthy, sympathetically active patients.
And the major limitation we talked about early on regarding mask induction.
Airway irritation. The pungent odor is its greatest flaw for induction. It causes coughing, salivation, breath holding.
So you just can't get a smooth induction with it.
You cannot safely or smoothly deepen anesthesia via inhalation with isoflurane. No.
And we also have to state the absolute genetic contraindication.
Yes. Isoflurane is a potent trigger for malignant hyperthermia, MH. It must be listed as an absolute contraindication in susceptible patients. That's a non-negotiable fact for any volatile agent.
Finally, what about common postoperative considerations?
Patients often experience shivering during emergence. This is a common post-anesthetic thermoregulatory response, and it's effectively treated with an agent like meperidine.
Yeah.
There are also some reports of non-thermoregulatory movement, like clonus and tonic stiffening, that can sometimes happen. But fortunately, the incidence of post-anesthetic nausea and vomiting, PONV, is generally reported to be pretty low.
Okay, let's just formalize the absolute contraindications and the necessary precautions for safe use.
Right. Beyond the absolute contraindication of malignant hyperthermia susceptibility, we have to focus heavily on fluid status. Patients with severe hypovolemia need extreme caution.
Because of vasodilation.
Exactly. Because its primary effect is vasodilation, a volume-depleted patient might not be able to compensate, leading to exaggerated, life-threatening hypotension.
We covered coronary artery disease, but what about patients with pre-existing kidney problems?
Because of the minimal metabolism, isoflurane is actually highly favorable in patients with pre-existing renal impairment. The low fluoride levels mean it poses virtually no risk of acute kidney injury.
But you still have to be careful.
Of course. You always need to ensure adequate renal perfusion because hypotension from any cause can compromise the kidneys.
Finally, the critical safety precaution with low-flow anesthesia and CO2 absorbance. This is a classic exam trap.
This is a vital distinction you have to master. Isoflurane can react with dry CO2 absorbance, specifically desiccated soda lime, to produce carbon monoxide, or CO.
Not compound A.
It's not compound A. This is a serious hazard causing elevated carboxyhemoglobin levels. So the safety mandate is clear. Always make sure there's moisture in your absorbent.
And what about special populations like neonates?
In pediatrics, particularly neonates and infants, the MAC is higher. This means you need higher concentrations for effect, which increases the likelihood of side effects like that SVR-driven hypotension.
But you wouldn't be using it for induction anyway.
Exactly. Its pungency generally means you're not using it for mask induction in this group. Sevoflurane is the agent of choice for children.
For your long answers, the examiners expect you to be able to compare agents critically. Let's create those key tabular data points.
Right. We have to structure the comparison around the 4 major differentiating characteristics.
Go ahead.
First, solubility, which dictates speed. Halothane at 2.5 is slowest. Isoflurane at 1.4 is intermediate. Sevoflurane at 0.65 is fast.
Okay.
Second, potency, or MAC. Halothane at 0.75 is most potent. Isoflurane at 1.17 is medium-low. Sevoflurane at 1.8 is least potent. Third, metabolism. Halothane at 20-40% is high. Isoflurane at 2-4% is low. Isoflurane at less than 0.2% is the lowest and safest.
And finally, airway irritation.
Fourth, airway irritation. Halothane is sweet and non-irritant. Sevoflurane is pleasant and non-irritant. Isoflurane is pungent and irritant.
Okay, let's dive deeper into the isoflurane versus sevoflurane comparison. That's a frequent short note question.
Sevoflurane wins hands down on induction quality. It's non-irritant, lower solubility. It's the preferred agent for inhalational induction, especially in kids.
But isoflurane wins on two critical points.
It does. One, metabolism. Isoflurane's 0.2% is safer than sevoflurane's 2.4%, making isoflurane arguably better for extremely long cases. And two, cardiac output maintenance. Isoflurane maintains cardiac output better because of that reflex tachycardia.
Whereas sevoflurane can cause more of a drop.
It causes minimal heart rate rise, leading to a greater dose-dependent drop in cardiac output. And finally, sevoflurane has the unique safety issue of compound formation with moist CO2 absorbance, a hazard isoflurane does not share.
And the foundational comparison. Isoflurane versus halothane.
This comparison justifies isoflurane's entire existence. Isoflurane causes less myocardial depression, maintains hepatic oxygen supply better, and doesn't sensitize the heart to arrhythmias.
And the metabolism is the biggest difference.
The 0.2% metabolism is dramatically safer than halothane's high biotransformation, virtually eliminating the risk of halothane hepatitis. And on the CNS front, isoflurane facilitates CSF absorption while halothane impedes it. Isoflurane is universally the superior and safer agent.
Let's distill the most likely questions you will face in that stressful Viva format. You need to be able to state these answers with confidence.
First, the absolute mandatory question. You will be asked to define IC and list 5 factors that decrease it. You should list age first, then hypothermia, hypoxia, hypovolemia, and opioids. Second, you have to be ready for the controversy. Explain the coronary steal phenomenon and its clinical significance with isoflurane.
And the sophisticated answer is?
The sophisticated answer immediately stresses the theoretical nature of the concern, cites the lack of confirmed clinical harm in humans, and emphasizes the importance of maintaining coronary perfusion pressure.
And the numerical drug interaction data is crucial here too.
Yes, you have to be able to quantify the reduction. How does fentanyl affect isoflurane MA? State the 1.67 nanogram per ml plasma concentration for a 50% reduction, and crucially, discuss the ceiling effect to prove you understand their role as adjuncts, not replacements.
Now let's clarify the most common absorption trap, the one related to CO2 absorbance. This distinction has to be crystal clear.
The common trap is confusing the degradation products. Compound A is exclusively associated with sevoflurane degradation when it's exposed to moist soda lime, and that carries a theoretical risk of nephrotoxicity. The fact about isoflurane is different. Isoflurane degrades to carbon monoxide when exposed to dry CO2 absorbance. You must never interchange those two hazards.
Okay. Final advice on framing safe, high-scoring answers, especially for high-risk patients.
When you're justifying using isoflurane in high-risk patients, always go back to the 3 pillars. Emphasize its preservation of cardiac output, its minimal metabolism, and its manageable CNS effects. And for the CNS discussion, explicitly differentiate the thresholds. CMR suppression peaks below 1 ms, but the undesirable CBF and ICP increase only becomes significant above 1 ms, making it manageable.
That distinction shows a deep understanding.
It does. It shows a deep understanding of neuropharmacology.
In a 20-mark written answer, describing a diagram can earn you extra points. What are the key visual concepts candidates should be ready to describe?
3 diagrams are essential for isoflurane. First, the uptake curve, the FAFI ratio. You have to describe how the isoflurane curve rises steeply faster than halothane but slower than desflurane, showing its intermediate speed.
Okay, what's second?
Second, the MSC reduction curve for opioids.
Yeah.
You should describe that nonlinear relationship between fentanyl concentration and isoflurane MSC, noting how the slope flattens out, visually representing that ceiling effect.
And the third one is for neuro.
Yes. The cerebral vasodilation graph. This is crucial. It visually shows that CMR suppression happens early and plateaus around 1 mmHg, while the CBF increase and the associated ICP risk only gets steep above 1 mmHg.
Okay, let's integrate all of this into the required structure.
Yeah.
How do you construct a perfect top-scoring 20-mark answer?
Structure is everything. You need clear, numbered, bold headings.
So start with an intro.
1. Introduction. Brief definition, isomer status, and the 3 pillars. 2. Physical properties. Use a table for the key numbers and their relevance. 3. Pharmacokinetics. Detail uptake and metabolism, emphasizing that 0.2% figure.
Then the biggest section.
4. Pharmacodynamics. This is the longest section. Use subheadings for CVS, respiratory, and CNS. The CVS section has to cover SVR, heart rate, cardiac output, and the coronary steel debate. The CNS section must differentiate the responses relative to 1 mmHg.
And then wrap it up.
5. Clinical uses, and 6. Advantages, disadvantages. Synthesize the profile into practical applications, and then a conclusion. A sophisticated summary paragraph.
Those headings are exactly what examiners look for to allocate marks.
They allow you to show both breadth across the system and depth on the high-yield sections like CVS and CNS.
All right, time to bring it all home. Let's provide that final mental checklist, the 3 pillars and the essential take-home facts.
We reiterate the foundation. The 3 pillars of Isoflurane.
1.
Intermediate blood solubility. Provides controllable speed.
2.
Minimal metabolism. Provides a superior safety margin.
And 3.
Cardiac output maintained. Provides high hemodynamic stability.
Give us the top 12 essential take-home exam facts that will guarantee a pass on this topic.
1. Structural isomer of Enflurane. 2. Pungent odor limits induction. 3. MIC is 1.17%. 4. MSC decreases with age. 5. Immobility site is the spinal cord. 6. TFA is the main metabolite. Fluoride is negligible.
Okay, halfway there.
7. Hypotension is from SVR drop. 8. CO is maintained via heart rate compensation. 9. Coronary steel is theoretical. 10. Reduces CMR below 1 mmHg, increases CBF above 1 mmHg. 11. Potentiates muscle relaxants more than halothane. And 12. Absolute MH trigger.
That's the inventory. Now, for the finishing touch, that model conclusion paragraph that will earn top marks on a 20-mark essay.
Okay, here is the model paragraph you should aim for. In conclusion, Isoflurane represents a highly favorable and foundational volatile agent, balancing moderate potency with desirable pharmacokinetics. Its cornerstone advantage is the minimal degree of metabolism, less than 0.2%, translating directly into a reduced risk of organ toxicity and providing superior safety compared to earlier agents. While its pungency limits inhalational induction, its preservation of cardiac output via reflex tachycardia, its predictable effects on the CNS, which are manageable by hyperventilation, and its proven safety profile in cardiac patients ensure its continued role as a reliable and cost-effective agent for the maintenance of general anesthesia in a wide variety of clinical settings.
That is a perfect synthesis of the high-yield material. You now have the exact structure needed to get maximum marks on this cornerstone topic. Make sure you review those comparison tables and the MAC modifier list. Those are your guaranteed easy marks.
And for your own deeper study, the kind of knowledge that truly separates candidates in Aviva, I'll leave you with this provocative thought. We know isoflurane is cardioprotective. If we accept this protective anti-ischemic property, how exactly do those protective molecular pathways override or nullify the historical theoretical potential for coronary steel, making isoflurane not just safe, but actively beneficial in the ischemic heart? That intellectual connection is what truly distinguishes a strong specialist. Go master this material. We wish you success in your examinations.